continue on talking about diabetes mellitus, there is type 2 diabetes and a kissing cousin called metabolic syndrome. I'm not going to go into metabolic syndrome in much detail. I save that for pathophysiology. But metabolic syndrome is not pre-diabetes. Metabolic syndrome is a myriad of disorders all at once, with only one of them being type 2 diabetes. It also includes hypertension, central obesity, etc. Type 2 diabetes is typically adult onset, but again, we can't always say that. There are children who are morbidly obese and they have type 2 diabetes. But usually it does occur after age 40. These individuals with type 2 diabetes may have appropriate levels of insulin release, but they just have the inability to respond to it. So we say they have down-regulated their insulin receptors. But that may not be a person's problem. Some people might not release enough insulin, or maybe someone has defective insulin receptors. So there are a myriad of reasons why a person can have type 2 diabetes, but it is associated with age and central obesity. We have to bring these people in and teach them how to control their diet. Again, see the dietitian. Encourage them to get regular exercise, lose possibly 5% of their current body weight. Just losing 5% of your body weight is remarkable. It reduces your risk of type 2 diabetes. It helps your body become more sensitive to insulin. It also decreases your risk of many types of cancer and other health complications. And now I have read, but it's not a real thing, I just have it up here, type 1.5. And this is a weird phenomenon. We're now seeing individuals who have type 1 diabetes, but they're not managing their weight well, and the very insulin they're injecting is no longer effective because they have had downregulation of their insulin receptors due to obesity. We are no longer the most obese nation in the world. Recently, Mexico won that honor, but we're number 2. We are a very obese nation. There are 20 million plus people who have diabetes, and only about 1 to 2% of that number is type 1 diabetes. The rest is type 2, which is considered to be preventable and highly manageable and can be reversed if the person really does make dietary changes and loses weight through regular exercise. Why is there a link between obesity and downregulation of insulin receptors? I have no idea. The studies are still coming through, but we know that there is a link. Moving on to exocrine secretions of the pancreas. These are secretions that I've already talked about, but here is one succinct slide for you to realize that the pancreas, through secretin, will release sodium bicarbonate buffer. This helps neutralize the acidic chyme from the stomach. It also releases zymogens, trypsinogen, chymotrypsinogen, and procarboxypeptidase that in turn are activated when they're in the duodenum. And then these are active digestive enzymes that can hydrolyze proteins. Then there are other enzymes like pancreatic amylase for carbohydrate digestion, pancreatic lipase for fat digestion, and RNases and DNases that can hydrolyze RNA and DNA respectively. What will happen to a person if they have pancreatic failure? Well, one type of pancreatic failure is to the islets of Langerhans only, in which case the person will have problems with diabetes mellitus, for example, and regulating their blood glucose levels. But if it's pancreatic failure down to the exocrine level, where the acinar cells are now compromised, well then a great many of the digestive enzymes comes from the pancreas. And now the person will have a problem with digesting their food, and if they can't do that, then they're going to have a problem with absorption. I actually did have a student who had decreased pancreatic secretions, and there are drugs that she had to take that helped her with her digestion. Without pancreatic enzymes, 60% of your fat cannot be absorbed because you can't hydrolyze it into single fatty acids and the glycerol backbone. The fat will come out in your diarrhea. and this is called steatorrhea, and it's nasty. It is really fatty diarrhea. You also can't absorb 30 to 40% of your proteins and carbohydrates, and again, that's going to come out in your stool. Another problem with the pancreas is pancreatitis, which means your pancreas has had an inflammation response. And this can be explained because of trypsinogen being activated within the pancreas to trypsin. And now you're starting to digest yourself, or autodigestion. A person with acute pancreatitis, primarily the most common cause are gallstones. When the gallstones block the pancreatic duct, because the bile duct merges with the pancreatic duct to create the hepatopancreatic ampulla, the gallstones being a blockage means the digestive enzymes have more opportunity to activate themselves. Again, the culprit is trypsinogen activating itself to trypsin. Guyton and Hall actually talks about what I affectionately call a babysitter protein in the pancreas, whose job it is to make sure that trypsinogen doesn't auto-activate itself. But if there's a blockage from gallstones, this babysitter protein gets outnumbered by trypsinogen molecules, and then the trypsinogen activates itself. Acute pancreatitis is still very, very painful. The person knows where they are, and this can take easily 2 weeks to treat. Once the pancreas has enzymes that are catalyzing themselves to active form, this is very hard to stop that progression. The person is very sick, will be on pain meds, and they can guarantee being in the hospital for at least a week to even 2 weeks. Chronic pancreatitis, the most common cause is alcohol abuse. And if you have chronic pancreatitis, that means you are having multiple bouts of pancreatitis throughout a year. And I am here to tell you, if that alcoholic can't stop their ways, they will not be long for this world. With chronic pancreatitis, it is definitely life-threatening. The liver has over 500 functions. We could easily spend a whole semester on the liver itself. Let's talk about its role with the digestive system. You've already learned about how the liver plays a role for body fluid compartments with synthesis of albumin. You've also learned the role of liver with the hepatocytes to conjugate unconjugated bilirubin to conjugated bilirubin, and you know that conjugated bilirubin will come out with the bile. Hepatocytes also make bile. These bile salts help keep cholesterol dissolved. And if the bile salts do not do this, the cholesterol will precipitate out and create gallstones. In addition to making bile, the liver makes and stores many vitamins, helps process fat, and detoxifies your blood, in addition to making those blood proteins like albumin and clotting factors. These are just a few of the many roles the liver plays. Let's talk about carbohydrate digestion. This primarily begins in the mouth with salivary amylase, but this is minimal because once that hits the stomach, the low pH of the stomach will inactivate the salivary amylase. Carbohydrate digestion resumes in the duodenum, jejunum, and ileum once the pancreatic enzymes are released, along with the brush border enzymes. How do you get absorption of monosaccharides across the intestinal epithelial cell membrane? Well, the answer is co-transport. Allow sodium to diffuse into the cell, and it will pull along with it carbohydrates like glucose. Then the carbohydrate, like glucose, can be pushed into the bloodstream, which is on the basolateral side of the cells shown here in the bottom right. Then all of the blood that leaves the gut must go to the liver first through the hepatic portal vein for detoxification before it can return to the official cardiovascular system. So again, the enzymes used: salivary amylase, pancreatic amylase, the brush border enzymes that I mentioned before. What about protein digestion? Where does it begin? Protein digestion begins in the stomach with pepsin. Pepsin comes from pepsinogen that's been activated by hydrochloric acid. The actual absorption of single amino acids is very similar to glucose. It's co-transport. Sodium diffuses into the cell and it pulls along with it amino acids. There are also enzymes that come from the pancreas, like trypsin, chymotrypsin, and carboxypeptidase, which were activated by enterokinase, as well as the peptidases from the brush border enzymes. Again, absorption of most of your digested polymers that have been digested to monomers is linked to sodium absorption in the small intestine. Look on the right side of this picture. You're seeing secondary active transport, diffusion of sodium into the cell, and it pulls along with it amino acids and glucose. It can also have antiport, or where we have sodium diffusing into the cell and something being secreted into the lumen, as shown here for the sodium hydrogen antiporter or countertransport. And we also see that chloride follows sodium through an electrical gradient created by the absorption of sodium. So you get a lot of electrolyte absorption and nutrient absorption thanks to the sodium transport into the cell, diffusing down its electrochemical gradient. But how do you digest lipids and how do you absorb them? They are a different issue, because lipids, remember, are going to be lipid friendly, and they are going to pose a different issue crossing cell membranes. First of all, lipid digestion begins in the mouth, but it's minimal, so we're going to pretend that lingual lipase has minimal activity. It continues in the small intestine thanks to the pancreatic lipases and cholesterol esterase. This helps cleave the ester bond to release cholesterol from your food. There are also phospholipases that will release free fatty acids and monoglycerides. Bile salts are not enzymes. Bile is not a digestive enzyme. It merely emulsifies liquid drops. If you look at my picture here, there's one big fat globule up at the top of the picture. Bile has both polar regions and nonpolar regions. That means it's amphiphilic. So the polar regions, if you look at this picture, orient towards the liquid that's in your digestive tract from your diet, something you just drank, and the nonpolar regions are going to associate with that fat globule. And what the bile salts do when they emulsify is they take a large fat globule and basically reduce it to many smaller fat droplets. And because these fat droplets are smaller and suspended in water thanks to the bile salts, this gives more surface area for the true digestive enzymes to reach those triglycerides and start to hydrolyze them into free fatty acids and the glycerol backbone. Now, what happens when you get your free fatty acids? As you can read, and I'm not going to read this, the fatty acids are able to get through the cell membrane. They are lipid soluble. When they enter the intestinal cells through diffusion, the bile salts are released and can be reused. Then the fatty acids and monoglycerides are going to combine with special proteins within the cells. And this combination leads to really small fragments called chylomicrons. And then the chylomicrons are exocytosed, and then they go into a lacteal. I don't have a lot of time to go into cholesterol management. I just want you to know that these chylomicrons carrying fats and cholesterol will now enter the cholesterol pathways. And if you want to learn about those in more detail, we cover it extensively in pathophysiology. Now, you have fluid entering your gut and leaving your gut. Let's talk about the fluid entering your gut. One is from your diet, the actual water you consume. You also produce more water. When you release your digestive enzymes, they are released in copious amounts of water. So you've got liters worth per day produced from saliva and even stomach secretions, not to mention bile and pancreatic juices. And the small intestine can also contribute. Now, where do you get most of your water absorption? From your small intestine. Liters worth from the duodenum and jejunum, and a biggie is from the ileum acting by itself. The large intestine also participates in water and electrolyte absorption. In the end, you have a minimum amount of water that must go along with your fecal material in order to allow it to slide out of your body. If you do not have enough water in your diet, and your fecal material doesn't have enough water to help it being removed from the body, your fecal material will become impacted and it will be painful for you to pass. We say you're constipated. So the water is absorbed as you absorb your nutrients. As sodium and your amino acids and glucose are absorbed, water must follow, right? The particles are drawing the water along with them. So it's simple osmosis that explains how we absorb the water from our gut. Again, the large intestine is not really a site of chemical digestion anymore. It really is a site where we have further water reabsorption and electrolyte absorption. And we also have bacteria throughout the large intestine that can help with several vitamin synthesis, like vitamin K and biotin and B5. There are other GI disorders that are worth noting. GI disorders in general are really diseases that result in decreased absorption, even when food is well digested, and they're classified as sprue. Non-tropical sprue is also called celiac disease, where the person has an allergy to gluten, and this is a protein found in wheat and rye. And I alluded to some earlier that this destroys the microvilli, which provide a huge amount of surface area. And if it's really bad, it can even lead to the destruction of the villi themselves, again, impacting surface area for digestion and absorption. Tropical sprue, we believe, is caused by a bacterial infection, and the way we treat that is through antibacterial agents. There is no known cure for non-tropical sprue, but we do know that it's all the rage right now to be gluten-free, right? And most of us do not have gluten allergies, nor are we sensitive to gluten. I'm not saying that it's healthier to avoid gluten. I wouldn't necessarily buy into that, though a lot of health conscientious people say we should avoid it. Most of us don't have a problem with digestion of it. It does seem to be linked with people from European descent, especially Caucasian descent. There's a link. We think there might be a protective reason, evolutionarily, why it evolved that way. And we do study gluten allergies in more detail in pathophysiology. I already told you what steatorrhea is. This is fat in your stool. It's very runny, and this is because you've either failed to digest your fats or you couldn't absorb them. Constipation is slow movement of the feces. You get irregular bowel movements, so that's why it's really important that you make yourself have regular bowel movements. If the feces is not moved along, the water is reabsorbed too much, and now you've got rock-hard impacted feces, as shown here in this megacolon. This is called Hirschsprung's disease, and we believe it's a deficiency of the ganglion cells in the myenteric plexus. So the person basically has a lazy gut, as we say, and the fecal material isn't moved along, and it gets really impacted and hard to pass and very painful. We suspect my niece has this. She's better now because her mom has learned how to keep her regular, but when she was a toddler and we didn't realize she had this problem, she would get a really large distended belly and just full of feces, and you could feel it when you pressed on her belly. And when she finally did have a bowel movement, it was extremely painful with a lot of crying, and that wanted her not to go to the bathroom even more, which of course exacerbates the problem. So we want children and adults to have regular bowel movements. We say don't be FOS or full of, you know what the S stands for. And there are actual nurses that have to teach young children and teenagers, because these are the two populations that are more likely not to go to the bathroom on a consistent basis because they're with their peers all the time and they're embarrassed about it. These nurses actually have to teach the children how to, it's basically physiotherapy, how to recognize when your body is telling you or giving you a signal and what do you do about it. All right, that concludes our physiology of the digestive system.